Good morning to everybody. First, I would like to thank Kandy Society of Medicine for providing this invaluable opportunity to deliver this lecture. Topic I am going to discuss today is on ECGs in clinical practice. As you all know, ECG is a very common investigation. We do make requests during our day-to-day clinical practice. ECGs are useful to diagnose and manage cardiac emergencies, for the preoperative management of patients, as well as diagnosis, management, and follow-up of almost all of cardiac ailments. Therefore, we should know how to make the proper request for ECG. This request form is available in our hospital, and after completing the top part of the form, you have to add these 3 points into your request form. That is 12 lead ECG, that is the first one you have to include. Standard ECG consists of recording on 12 leads. Then lead 2 rhythm strip is a fairly longer recording which is done on lead 2. That is because the lead 2 is the best lead to diagnose rhythm disorders. The axis of lead 2 lies on the cardiac vector. Therefore, to analyze rhythm disorders, to diagnose rhythm disorders, you have to analyze lead 2. Then V4R lead should be included. In case of myocardial infarction, V4R lead will show ST segment elevations in case of ST elevated RV infarction. This is the professional way of handling the ECG. Let the ECG strip to run between index and the middle fingers, and keep your hands wide apart. First, let's discuss rhythm disorders, synonym arrhythmias. As you know, the rhythm disorders can vary from single beat abnormality to malignant sustained arrhythmias. The definition of sustained arrhythmias is any arrhythmia which continue for 30 seconds or more than that, or need early termination due to unstable hemodynamic state of the patient. Those arrhythmias are termed sustained arrhythmias. Coming to the classification of arrhythmias, according to ventricular rate criteria, there are 2 types, tachyarrhythmias and bradyarrhythmias. The tachyarrhythmias mean the ventricular rate is more or equal to 100 beats per minute. The bradyarrhythmias mean the ventricular rate less or equal to 60 beats per minute. But as you know, the arrhythmias can occur when the ventricular rate in between 60 and 100. As an example, in case of atrial fibrillation, with the controlled ventricular rate, the rate will be 80 or 100, but there is ongoing atrial fibrillation. This slide shows 12 lead ECG with a narrow complex beat here, which is coupled with a broad QRS complexes. Now, you can see a short pause. So, if there is a pause, we have to find out why. So, this pause could be a compensatory pause. It could be a sinus block, sinus pause, or it could be due to sinus arrhythmias. So, what is the diagnosis of this pause then? So, these are sinus beat. It is coupled with a broad QRS complexes, and it is followed by a pause. So this is a compensatory pause. These broad QRS complexes are the ventricular ectopic beats, and this interval between the sinus beat and this abnormal beat is called the coupling interval. So this coupling interval is short, therefore this is a premature contraction. So this is a premature ventricular contraction which is followed by a compensatory pause, and in bigeminy, every other sinus beat coupled with the ventricular ectopic beat. So this patient was referred because she had clinically significant bradycardia. That is because this this ventricular ectopic beat give rise to drop beats. Therefore, the ventricular rate will drop to half. Classification of sustained tachyarrhythmias, there are 4 types. The classification criteria are the RR interval and QRS duration. The RR interval means the interval between 2 adjacent R waves. It can be regular or irregular. Then the QRS duration, the normal QRS duration is less than 0.12 seconds. If the QRS duration is 0.12 seconds or more, those QRS complexes are called broad QRS complexes. If the QRS duration is less than 0.12 or less than 3 small squares, these are called narrow QRS complexes. According to these 2 criteria, there are 4 types of tachyarrhythmias. Regular narrow complex tachycardia is the commonest type of tachyarrhythmia. There, the RR intervals are regular and the QRS duration is narrow, less than 0.12 seconds. Then irregular narrow complex tachycardia mean the RR intervals are irregular, the QRS complexes are narrow. Then third category is regular broad complex tachycardia. RR intervals are regular. The QRS duration is more or equal to 1.2 seconds. Then the fourth category is irregular broad complex tachycardia. The RR intervals are irregular. The complexes are broad. When you get the ECG with tachyarrhythmia, when the ventricular rate is more than 100, if you can use this approach, it will be easier for you to make the correct diagnosis. The first step is it what type of arrhythmia? Whether it is regular narrow complex tachyarrhythmia, irregular narrow complex, regular broad complex, or irregular broad complex. Then the second thing you should know is what are the examples of each type. Then analyze the baseline of the ECG. Then by analyzing baseline, you can categorize the examples and you can narrow down your diagnosis. Then finally, look for characteristic features of some tachyarrhythmias. As an example, if you get regular broad complex tachycardia, in 85% chance it to become ventricular tachycardia and 15% chance it to become supraventricular tachycardia with broad QRS complexes. Therefore, you should know what are the diagnostic features of ventricular tachycardia. Those are the characteristic features you have to look for to make your correct diagnosis. Now look at this ECG and let's apply that approach. Now here rate is around 100. RR intervals are regular and the QRS duration is narrow. So this is regular narrow complex tachycardia at a rate of 100 beats per minute. Then second thing, you should know what are the examples for regular narrow complex tachycardia. This slide shows that commonest is sinus tachycardia. Then second commonest is supraventricular tachycardia. Atrial flutter with 1:1 AV conduction or atrial flutter with 2:1 AV block. Atrial tachyarrhythmia with 1:1 AV conduction or atrial tachycardia with 2:1 AV block. So these are the examples. Now by analyzing the baseline, you have to narrow down to find out what is the cause. Let's move to the previous slide again. Now second step is analyze the baseline. By analyzing baseline, look for atrial activity before the QRS complex and after the QRS complex. Now, in this slide, before each QRS complex, you can see smooth P waves. Is it in sinus rhythm? In sinus rhythm, these P waves are smooth and they show positive deflection. in every lead except in lead AVR and V1. In AVR, during sinus rhythm, P wave is inverted. In lead V1 is also P wave is inverted. Therefore, this ECG is in sinus tachycardia, shows sinus tachycardia. So diagnosis is sinus tachycardia at a rate of 100 beats per minute. In every arrhythmia, you have to mention the rate at the end. This sinus tachycardia is also categorized under long RP tachycardia. Long RP tachycardias mean this atrial activity is seen before the QRS complex. Therefore, the RP interval, the interval between previous R with the consecutive P wave is long. Therefore, it is under long RP tachycardia. Then let's apply that approach to this slide as well. Now, this is again tachycardia rate around 170. RR intervals are regular. And the QRS duration is only 2 small squares. That means less than 0.12 seconds. Regular narrow complex tachycardia at a rate of 170 beats per minute. Now, you knew the examples by now. Now let's analyze the baseline. This is the lead to rhythm strip. If you analyze the baseline before the QRS complex, you can't see any deflections. But after the QRS complex, you can see a very low amplitude S wave here. So this is the retrograde P wave. So this is regular narrow complex tachycardia with retrograde P waves. The same sequence is there in cyclical manner. So this is supraventricular tachycardia. So what is the consequence? What is the sequence you see? QRS complex, ST segment T, isoelectric baseline. QRS complex, ST segment T wave, isoelectric baseline. So there are no any deflections here. So this supraventricular tachycardia is categorized under short RP tachycardia. There the RP interval, the interval between this R wave to this retrograde P is very short. So this is categorized under short RP tachycardia. Now this rhythm strip, again, very fast tachyarrhythmia at a rate of 232 beats per minute. RR intervals are regular, QRS complexes are narrow. So again, regular narrow complex tachycardia at a rate of 232 beats per minute. If you see regular narrow complex tachycardias rate above 230 and below 300, you have to consider the possibility of atrial flutter with one-to-one AV conduction. During atrial flutter, atrias beat with suboptimum contraction at a speed of 230 to 300 beats per minute. As there is suboptimum contraction, there is a tendency of forming atrial thrombi, giving rise to systemic thromboembolism. So here, if you go through the baseline now, you can see QRS complex, T wave, QRS complex, T wave. You can't see the isoelectric baseline because of this fast rate. So here you can give differential diagnosis, atrial flutter with one-to-one AV conduction or supraventricular tachycardia with fast ventricular rate, fast supraventricular tachycardia. It is very important to differentiate these two. To manage this patient, if you give a DC shock or IV amiodarone bolus, this tachycardia will stop abruptly. Therefore, we can't find out what activity is going on there at the atrial level. Therefore, if you see this kind of case, please give a bolus of adenosine, 3, 6, 9, and 12 boluses. Then, if the AV node is blocked by those adenosine boluses, you will see this kind of rhythm. What happens when there is a AV nodal block? The flutter waves, all flutter waves cannot conducted, only few flutter waves will be conducted. So in this patient, what we could see is this sawtooth appearance. So this is atrial flutter with 1-to-1 AV conduction. Why should we diagnose this condition properly? If this is a female patient with CHEST score more than 3, or if a male patient with CHEST score more than 2, those patient needs long-term anticoagulation if it is atrial flutter. Next, the second category is irregular narrow complex tachycardia. You should know what are the examples. Atrial fibrillation, atrial flutter with variable AV block, atrial tachycardia with variable AV block, or multifocal atrial tachycardia. Some books categorize marked sinus arrhythmia under irregular narrow complex tachycardia. So let's go through this slide. So the approach, RR intervals are irregular, complexes are narrow. So this is irregular narrow complex tachycardia at a rate around 100, slow ventricular rate. Then you know the examples. Now let's analyze the baseline. The best leads to analyze baseline during tachyarrhythmia. There are two leads, lead V1 and lead 2. Now here in lead 2, you can see minor irregularity, but if you analyze lead V1, you can see very low amplitude fast deflections. And if you count the number of deflections within one large square, there are 2. So that means what should be the atrial rate? 600 wavelets per minute. So this kind of fast rate occurs during atrial fibrillation. During atrial fibrillation, if you look at atria, you can see tingling worms appearance, flickering. Then AV node always try to protect ventricles from these unwanted atrial impulses. It creates variable AV block. Therefore, the RR interval becomes irregular in case of atrial fibrillation. Now, as in atrial flutter, in atrial fibrillation, again, the contractions are not optimum. Therefore, there is formation of atrial thrombi and systemic thromboembolism. Now, in this case of atrial fibrillation, the ventricular rate is controlled. So this could be a case with atrial fibrillation with adequate rate control, or this can be a case of tachybrady syndrome. In tachybrady syndrome, the atrial fibrillation, atrial flutter, atrial tachycardia can occur. The same disease process, degenerative process, can affect the aortic valve as well, and therefore the AV blocks are more and more, giving rise to slow rate. In atrial fibrillation, if the ventricular rate is naturally slow, you have to consider the possibility of sick sinus syndrome. Next, we are moving to broad complex tachycardias. Let's know what are the causes of sustained broad QRS rhythms. As you know, complete bundle branch block, either right bundle or left bundle, monophasic ventricular, monomorphic ventricular tachycardia. 85% of broad complex tachycardias belong to this category. Then supraventricular tachyarrhythmias with broad QRS complexes. Now here supraventricular tachyarrhythmias could be SVT, it could be atrial fibrillation, atrial flutter, anything. Then what are the mechanisms of having broad complex rhythm in supraventricular tachycardias? If a patient is pre-existing either right or left bundle branch block develop one of those supraventricular tachyarrhythmia, so that patient's ECG will show broad QRS complexes. And during the tachyarrhythmia, if the patient develops rate-dependent either right bundle or left bundle branch block, so that is called rate-dependent bundle branch block or aberrant conduction, or we write on the diagnosis as aberrancy. Then patients with supraventricular tachycardia, and it is due to accessory pathway conduction, some patients can develop broad complex tachyarrhythmia because of this accessory pathway antegrade conduction. These are the three mechanisms from which the supraventricular tachycardia can present with broad QRS complexes. Then you have to remember that the hyperkalemia can present as broad complex tachycardia. Then the ventricular pacing, because of the presence of capture beats, can give rise to broad complex rhythms. Now this ECG, you can see abnormal ECG with rate around 100 beats per minute. The QRS durations are broad. There are about 5 small squares. The best lead to measure the QRS duration is lead V1. So this is regular broad complex tachycardia. Let's analyze the baseline. So you can see sinus P wave precedes each QRS complex with normal PR interval. Now there again, the P waves are upright, but in AVR it is inverted, and in V1, biphasic P wave is there. The press component is due to right atrial contraction. The second component is due to the left atrial contraction, and it is inverted during sinus rhythm. So this is broad complex rhythm, and there is sinus tachycardia. Then this could be either right bundle or left bundle branch block. How to differentiate? Next step is analyze lead V1. If you analyze lead V1, you can see dominant negative deflection, the broad and higher amplitude S wave, which is preceded by very low amplitude R wave. So this is a simple R, capital S complex. If you see this complex, your diagnosis is most likely to be left bundle branch block. To confirm that, you have to look at lead V6. So in lead V6, in left bundle, you can see a tall, broad R wave, and the notches can be seen. These notches are due to slow conduction. Slow conduction. Now in lead 1 also, you can see the tall, notched R waves and broad base. So this is left bundle branch block with sinus tachycardia. Now in this patient, this R wave indicate that this is ischemic left bundle branch block, could be acute or old. In non-ischemic left bundle, usually you can't see this R wave, you will see only the QS complex, complexes like this, QS complex. Now this ECG, there is no tachycardia, but I selected this ECG to discuss about another cause of broad complexes. Now again, in sinus rhythm, broad complexes are there. In AVR, P wave is inverted, and this is biphasic. And if you analyze lead V1, you can see 2 R waves, and there is a S wave in between. The amplitude of the first R is less than the amplitude of the second R. So this morphology of QRS complex is called rabbit's ear morphology. The first R is termed as simple R. The second R, followed by a S wave. Then the second R is termed as capital R dash. So this is RSR dash morphology. This configuration is seen in right bundle branch block. To confirm the right bundle, next we have to analyze lead V6 and lead 1. In lead V6, there is a greater amplitude R wave followed by a low amplitude S wave with broad base. So this is a slurred S wave. The RS ratio is more than 1 in this beat. To confirm the diagnosis of right bundle branch block, the RS ratio in V1 should be more than 1. And look at lead 1, you can see slurred S wave here. If the axis is normal, you will see the RS ratio again greater than 1 here and the slurred S wave. So this is right bundle branch block. Now this ECG shows again regular RR intervals, broad QRS complexes at a rate of 170 beats per minute. Regular broad complex tachycardia. Now it could be one of the example as I discussed. Now let's go through the ECG. But you can see the QRS complex T wave and the baseline, QRS T and baseline, the QRS complex T and baseline. You can't see any atrial signals. So next, the now possibilities are whether this is ventricular tachyarrhythmia or supraventricular tachycardia with one of the bundle branch block. So another feature you have to look for, look at lead V1 and look at lead V6. There are some characteristic features. In lead V1, you can see the RSR dash morphology, second R amplitude is greater than the first R. And in V6, you can see stirred S wave, but the amplitude of S wave is greater than lead V6. To diagnose this slide correctly, you should know what are the diagnostic features of ventricular tachycardia. Now let's go through this slide. These are the diagnostic features of ventricular tachycardia. AV dissociation, presence of capture beats, and presence of fusion beats make the diagnosis of VT. So what happened here? During ventricular tachycardia, atrial contraction does not give rise to ventricular contraction. The independent contraction of atria and ventricles occur. Therefore, you will see AV dissociation. Then those sinus P waves may enter through the AV node and can depolarize the ventricles, giving rise to narrow QRS complexes similar to patient's intrinsic rhythm, normal rhythm. These are called capture beats. This usually happens in patients with slow ventricular tachyarrhythmias. Then conducted those sinus beat may fuse with the electrical impulse released from the focus in the ventricle, giving rise to fusion beat. To diagnose fusion beat, the ECG, you should see beats during ventricular rhythm as well as you have to compare this beat with the beats during sinus rhythm. The configuration of this fusion beat lies between normal sinus beat and the ventricular beat. Then the negative and positive concordance. From V1 to V6, you will see dominant S wave in negative concordance. In positive concordance, you will see V1 to V6 R wave. Then extreme axis deviation is a feature of ventricular tachycardia, and it is a feature of malignant hyperkalemia as well. Then look at tall R waves in lead AVR. The presence of tall R waves in lead AVR confirm the diagnosis of ventricular tachycardia. Then at the beginning of the monomorphic ventricular tachycardia, if you see R on T phenomenon, that is ventricular tachycardia. If none of these features are there, you have to analyze lead V1 and V6 to make your diagnosis. There, if you see left trapezium morphology, that means there is notched R wave in lead V1 and the amplitude of first R is taller than the amplitude of second R, that is called left trapezium morphology. It makes the diagnosis of VT. Then if there is a monophasic wave in V1, that means R wave in V1, that is again VT. And in some patients, there may be biphasic QRS complex. That means Q wave and R wave, QR complex or RS complexes in V1. Again, it makes the diagnosis of VT. Sometimes you will see RSR dash morphology, like in right bundle in B1, but if you analyze lead B6, the RS ratio is less than 1. So it can't be complete right bundle branch block. That is a case of ventricular tachycardia. In case of polymorphic VT, after termination, the ECG will show long QT, corrected long QT interval. Those are categorized under TOSAD is the pointers. Now let's move to previous ECG. Now you can't see the features I mentioned here up to this, those 9 features, but therefore we use number 10 features to analyze this ECG. Now here you can see rabbit ear morphology as seen in right bundle, but in V6, the RS ratio less than 1. So diagnosis is VT. There is another feature in AVR, you see a tall R wave. So this slide shows ventricular tachycardia at a rate of 170. Now this ECG, it shows broad QRS complexes, regular rhythm, and each broad complex is preceded by a low amplitude spike. This is a pacing spike. Now, this ECG, there is 100% pacing. Pacemakers are in demand mode. If the patient heart rate drops below the programmed rate of the pacemaker, in this patient, the program rate is 60. So patient rate has dropped below 60. Therefore, there is 100% pacing. But sometimes, as in case of tachybrady syndrome, periodically heart rate can go up above the program rate of the pacemaker. Then if you see the pacemaker, you can see narrow QRS complexes, and when the pacing appears, only you will see broad QRS complexes. Sometimes throughout the ECG, you can't see broad QRS complexes if the patient rate is higher than the program rate. Now, these are the examples for irregular broad complex tachycardia, the 4th category. Examples are atrial fibrillation with pre-existing bundle branch block. So patient with pre-existing bundle branch block has developed atrial fibrillation. It gives rise to irregular broad complex tachycardia. Then AF with rate-dependent bundle branch block or aberrant conduction, as I discussed earlier. Then the patients with WPW syndrome, they are having accessory pathway with fast conduction and very short refractory period. These patients with WPW syndrome are prone to develop atrial fibrillation. Then what happened? They develop irregular broad complex tachycardia. Another causes of irregular broad complex tachycardias are the atrial flutter with variable block, can occur in patients with pre-existing bundle branch, or it can be due to rate-dependent bundle branch, or atrial flutter also may conduct through the accessory pathway. Atrial tachycardia with variable AV block is also can present as irregular rhythm, and one of these things are there, then they will develop broad QRS complexes as well. Now this ECG, a young boy got admitted, had a cardiac arrest, and now what is the category? This is irregular RR intervals with broad QRS complexes. What is the rate? So you can see these two R waves within one large square. That means 300 beats per minute. It's a very fast, irregular, broad, complex tachycardia. Patient was in cardiac arrest, defibrillation was done, and patient was saved. And if you analyze this ECG, you can see broad base of these QRS complexes. These are due to accessory pathway conduction, delta waves. Because of these delta waves, this ECG becomes, these QRS complexes become broad. So this is atrial fibrillation with pre-excitation. In this case, you should not give, as you know, digoxin, adenosine, or verapamil. Moving to bradyarrhythmias, the rate less than 60 beats per minute. Now, this ECGs belong to a patient who was referred before undergoing minor surgical procedure under local anesthesia. The rate was, though it was 51 here, the rate was around 30 beats per minute. Then the PR interval also prolonged. Then we check the rate of the, speed of the ECG which was done. It was 50 millimeters per second, double speed. The speed of normal ECG is 25 millimeters per second. Therefore, if you see bradycardia, before you make your diagnosis, please look at the speed of ECG. If it is 50 millimeters per second, repeat the ECG with 25 millimeters per second. That is the standard speed of doing ECG. In 50, you will get bad bradycardia. Now, this ECG shows again bradycardia at a rate of 30 beats per minute and analyze the baseline. You can see QRS complex with T wave, isoelectric baseline, QRS with T wave, isoelectric baseline. You can't see any atrial signals. So this is nodal bradycardia. Nodal bradycardia is not uncommon in our hospital because the hyperkalemia often diagnosed as causing nodal bradycardia, because what happened in hypokalemia, plus the P wave amplitude will reduces and it will disappear. Then with that, the T wave become taller, tall T with narrow QRS complex. So this is nodal rhythm. Always do the potassium level in this kind of patients. Now this ECG again show bradycardia rate is not that bad, around 50 beats per minute. And on the baseline, you can see P waves, sinus P waves, and look at the PR interval. It's very close here. It's prolonged. Then another P wave behind the QRS complex. Here getting shorter further, then hiding, then prolonged PR. So that means the PR interval is variable. That says there is AV dissociation. So if there is bradycardia with AV dissociation, you can make the diagnosis of complete heart block. So this is complete heart block at a rate of 50 beats per minute. QRS complexes are narrow. Therefore, the rhythm is fairly stable. Now this slide, at the beginning, you can see tachycardia with broad QRS complexes, followed by only P waves on the baseline. So there is no ventricular contraction, only atrial contraction is there. So this is called ventricular standstill. This rhythm can complicate with complete heart block. Patients with complete heart block and broad QRS complexes can end up in this. And trifascicular block. You know what is trifascicular block? Right bundle branch block with axis abnormality plus prolonged PR interval. Those patients are at high risk of developing this rhythm. So this is ventricular standstill. Ventricle does not contract. Now let's move to ECGs with myocardial infarction. Making the diagnosis of myocardial infarction, you have to include these 5 things. First, time duration, as in any disease condition, acute, recent, or old. Then type of MI, ST elevated MI or non-ST elevated MI. Then the area involved, extensive anterior, inferolateral, high lateral, so on. Reciprocal changes, if present, and the rhythm disorders, if present, you have to mention. What beginners do, they get the ECG to their hands and they start analyze the ECG starting from lead 1. Then lead 1, 2, 3. Then they move to AVR, AVL, AVF. Then V1 to V6. Then at the end, rhythm strip and V4R if available. By analyzing last few leads of the ECG, they can't remember what was there at the beginning. Therefore, if you can use this algorithm. These steps, if you can follow these steps, you will not miss any lead. First, analyze lead 1 and AVL. This is called high lateral leads. These two behave in the same way. This is one electrode beam. Then, second step, analyze lead 2, 3 AVF, inferior leads. If there is ST elevation in these leads, you have to look at lead V4R. That's why we included lead V4R in our request form. Third step, analyze lead AVR. If there is ST segment elevation, you have to suspect left main coronary artery occlusion. Then the fourth step, analyze lead V1 to V3. In lead B1 and AVR, in a normal ECG, all the deflections appear as negative. P wave negative, T wave negative, and there is dominant S wave. In lead B1, if there is a R wave, tall R wave, then you should know what are the causes for that. What are the causes? True posterior myocardial infarction, left-sided accessory pathway, true dextrocardia, right bundle branch block. You will see rabbit's ear morphology, and severe pulmonary hypertension can cause R wave in B1, and in children again you will see R wave in B1. Then you have to analyze the ECG in that terms as well. Then look at V1 to V3 anteroseptal leads. If there is ST segment elevation, you can make the diagnosis of anteroseptal ST segment elevated MI. If there is ST segment elevations with QR morphology in lead V1, your diagnosis is anteroseptal STEMI complicated with ischemic right bundle branch block. The features of ischemic right bundle branch block is there is QR morphology in V1 to V3. Then ST segment depressions are there, suspect through posterior MI, and get the extended chest leads V7 to V9. Step 5, analyze V1 to V6 all together. Look for the R wave progression and all the abnormalities. Then finally analyze six step lead to rhythm strip for rhythm disorders. Now this ECG is an abnormal ECG. You can see sinus tachycardia, and here at the end there is ventricular fibrillation. This patient had suggestive chest pain followed by cardiac arrest while getting the ECG. So let's analyze the ECG according to those steps. First step, analyze lead 1 and AVL. So there is ST segment depression. Next, analyze 2, 3 AVF. ST segment elevations are there. So V4R lead is not here. Next, analyze lead B1 to B3. You can see R wave with ST segment depression followed by ventricular fibrillation. So what is the diagnosis? Time duration, obviously acute. ST elevation or non-ST elevation MI. ST elevation myocardial infarction, inferior and probably through posterior wall with reciprocal changes, complicated initially with sinus tachycardia followed by ventricular fibrillation. So these ST depression in lead 1 and AVL are caused by this. These are the reciprocal changes of this acute ST elevated inferior MI. This is because the inferior wall of the left ventricle lies opposite to the high lateral wall of the left ventricle. Similarly, the true posterior wall of the left ventricle lies opposite to the anteroseptal wall of the left ventricle. Therefore, if there is a true posterior STEMI, V1 to V3 will show ST segment depressions. This patient was managed and underwent stenting. Coming to the management of arrhythmia. Now, the first step of management of arrhythmias, evaluate the patient's hemodynamic state. Now, there are 10 features to look for. Patient is hemodynamically unstable if there is ongoing angina. Patients with tachyarrhythmia and bradyarrhythmia, they give history of tightening type chest pain, ischemic features, then evidence of cerebral hypoperfusion. Patient can be drowsy, can be confused, can have generalized
Miss, you seem to have muted yourself. Uh, excuse me, Miss. Miss, your mic has been muted. Hello? Miss? Hello, ma'am. Doctor?
In chronic bradycardia, patient can have high systolic blood pressure. It does not mean patient is stable, but those patients may have evidence of other organ hypoperfusion like brain hypoperfusion like drowsiness and heart angina or reduced urine output. Then evidence of pulmonary congestion, and the patients can have normal ejection fraction, but because of bradycardia, they end up in pulmonary congestion. So if these features are there, patient, at least one feature is there, patient is hemodynamically unstable. Then coming to the management of bradyarrhythmia, temporary transvenous pacing is the gold standard of management. Then the transcutaneous pacing can be used. When you adjust the pacemaker rate of transcutaneous pacemaker, you have to count the heart rate, whether there is a comparable increase in heart rate occurs with the pacing rate. Because the monitor will show high amplitude pacing spikes and you will misrecognize them as capture beats. But those are high spike pacing spike. Therefore, you have to check the heart rate to find out whether the heart rate has increased according to the program rate of the pacemaker. Then IV atropine is your friend. IV isoprenaline, IV dobutamine can be used. IV noradrenaline can cause bradycardia. Remember that. The amlodipine, salbutamol, osiprenaline can be used to manage mild cases. Thank you.